Thank you. So I want to first thank Luis for inviting me, and I'm going to try religiously to be on time, unlike some of my colleagues. It's because, I mean, there's some other people, they're not having gave talks, but I'll be there on 15 minutes exactly. And then if you have any question, we'll discuss that after that. So this is how we do it in America. This is, when you talk about ICAD disease, you cannot not discuss Sambra's trial. And even though Sambra's trial has many flaws, it kind of set the stage, if you will, for the treatment of intracranial atherosclerotic disease. The way it's set up, as all of you were aware, the patient was randomized to two groups, aggressive medical management, which included aspirin, Plavix, and cholesterol medication, and the second group, which is angioplasty and stenting. There was two outcomes, but they had to stop the trial, and the reason why, because the primary outcome here, which is the incidence of stroke or death over 30 days from the start of randomization. So this is what the conclusion, as you see here. And one thing you notice, the first thing comes to your mind is the top dotted line is the angioplasty and the medical group. So in the first 30 days, the risk from complications was 15% in the surgical group, which is upfront. The medical group was about 5.4%. 5.4%. So from there, it set the stage for the trial to fail, okay? And there are many reasons for that, the way it's set up that way. One of it, when they calculated the sample size, they went back to the Wasset trial. And from the Wasset trial, the first rate for 30 days from medical group was 10.7%. In Sambra's trial was half of that. And the same thing over 1 year was 25%, and they used that for calculation, and it turned out in the Sambra's about 12.2%. So by using these numbers, you already set up the trial to fail completely. So that's number one. Number two, so they have a lot. I'm viciously against the Sambra's trial, even though it was intended to and well designed. I mean, I'm saying well carried, but the design was flawed. The second thing, the system they use, the wingspan we use is over microwire exchange, balloon, and then the stent. That's where they happen. Most of the complications is with the micropuncture. And also, they did that. They never published. It depended on the group who did the procedure. They looked at different groups from interventionists, and there was different complication rates. So all that set up the trial to fail. Okay. Example. So here, this is in a patient. I do not use wingspan. I use Rebel, which is a cardiac balloon-mounted stent, and I've done over 63 cases. My colleague here, Dr. Simaniago, he's well experienced too, and done it too. So here's a severe stenosis. You go in, you do the balloon, it looks perfect. But the complications that could happen of this, right here, stenosis, you get subarachnoid hemorrhage. You put the stent, a thrombose or dissect. So these are the complications that people saw during the procedure. So from there, and because of that, we have a dilemma now where the FDA cannot allow you, and the insurance would not pay for it unless the patient failed twice. Not once, twice. Not once, twice on aggressive medical management. So if it was your brain and you had one time a stroke on aspirin Plavix, you cannot have a procedure unless you fail twice. Who wants that? No one wants that. So it's bullshit. But we have it and we have to work with it. And here, not only that, they found out that the primary event rate on aggressive medical management, there's 14 to 15% would fail. So even with that, with them being an aspirin and Plavix, there's 15% will fail. So it's kind of like now taking a Russian roulette. I'm going to put you on aspirin Plavix, and you just have to roll. And guess you could be either from the 85% or could be the 15%. So I had a judge who's a federal judge, I mean, way up high, 54 years old, sitting on the court. He had expressive aphasia. So he came to me, and he was out for 3 months. So we put him on aspirin Plavix. I explained the Sambers trial, and I said, I'm not going to treat you because, first of all, you have to pay for it. Second of all, if something goes wrong, I'm liable. And he goes, your doctors are stupid. Why would I go again and lose my job if this happened? You tell me there's a chance of 15%. I'm fair 54. Something's bad is going to happen. So that's where we are. So right here, okay, so be given that 15%. This patient, there's 2 different patients. Tell me which one is going to have a stroke on aspirin and Plavix and cholesterol. So you're guessing. So do you want me to guess on your brain? No, you don't want that. So we have to find a way to objectively and better and challenge ourselves to learn how to measure this and improve. So here again, there's 2 patients. If you put one of them, if you put both of them on aspirin Plavix, and I'll tell you which one is we're going to be in a little bit. One is going to do okay, and one is going to have a stroke. So how do we do that objectively? One of the things that that Mark Shimowitz and his Hemodynamic
stroke or embolic stroke?
It doesn't matter. We'll talk about it. Yeah. So this is where we are. So one of the things they're looking at it now is going back to the Sambers trial, and we have a calendar day, and one of our colleagues now in the University of Iowa, he was part of this investigator teams. You look at the watershed area. So if there's a watershed area, strokes or hits between this, then that can give you its hemodynamic, and that would suggest that even if it's aspirin Plavix, that patient could have another stroke. So that's one way you can objectively look at the problem. Exactly. Thank you, Sir Luis. So the other thing is looking at it, the 4D MRA, which is a NOVA. And one of our colleagues, Seppi, she's a genius young lady. She's been using that, and she already done that trial, but she only did it at the vertebrobasilar system. And it's using the 4D MRA. And the 4D MRA, you can calculate velocities, okay? And because you can calculate the velocities, you can estimate the pressure gradient across the stenosis. And based on that, you could say it's hemodynamic, and because of that, it's going to fail aspirin and Plavix, and this not the appropriate treatment. So you can measure here. You just got the lines, and this is being validated by Fadi Charbel. They did the rabbit study in the common carotid, and it works. But when it comes, see, this is another way you calculate it. This is the formula which calculate the pressure. You do the proximal plane, stenosis plane, and everything, and then you can see here there's differences based on the stenosis. But this has been only validated for the posterior circulation. And the reason for posterior circulation, because they don't have collaterals. When you have a robust collaterals, this fails, okay? Because now suddenly you have augmented flow. Because the calculation is dependent on this and this, and assuming this is 0. So if you have a good collateral flow in the anterior circulation, then this will kind of set up the equation and bias it. So you have to add to the delta BP some collateral flow, and that can change things. And it depends where you set it, or you set your threshold, then everything changed. So in posterior circulation, you could set your threshold as like 0.4 or 0.5, but if you have a good collaterals, you may have to increase that. So what we did is we learned from our cardiology. And you have to admit it, you have to accept it, you have to, that the cardiologist is 10 years ahead of us. And the interventional cardiologist, in their thinking and their way, is 10 years ahead of us. And they already done this for the coronary artery disease, especially the ones that questionable. They use the pressure gradient. What do I mean by that? You put the catheter right here. So again, we're going back to the same question. We're gonna address this very closely. So you put the catheter right here, you synchronize it with arterial pressure, and then you pass a microwire is 14, you have to pass distal. So you cannot do it proximal, you have to pass distal to the stenosis, and it give you the gradient pressure. And for that, you need this machine. This is the microwire over there, is 14 system, and this is the tower, and this is what you see right here, and it tells you the differences. Yeah, 14, yeah, 014. Yeah. So here's a patient. This is the patient that failed, that was on aspirin, Plavix, and failed, if you will, and we stented, and then this is not a perfect. Is it, okay.
Dave, did you measure
I was here.
Nova?
No, I don't have the Nova system. I wish I could have the Nova, and this is where we're gonna talk about it as the future directions.
Nova is the
MRA, the 4D, yeah, that 4D. So this patient, again, back to here, look at this. So this is right here. You see the top line is the right ICA. This is like the petrous segment, and this is post-stenosis. So there's a huge FFR. It stands for flow fraction reserve, and when you see that the fraction is 0.48, 0.48. So the pressure gradient across the stenosis is low. When you fix it and you do it, went up to 0.97, and this patient went in and have no problems for the last 2 years. Now, let's look at this one. So here, this patient, again, stenosis, and we measured it. And for the first, we didn't want to intervene because he was an older patient, and you see the FFR again 0.51, and this patient also progressed over 2 years to have another stroke, but not because of the flow. It was because of augmented embolic thrombo with it. Yeah. Now, going back again to the collateral flow. So here, how many of you would think after this patient, actually, Dr. Simaniago, he came in, he's a young guy in his 50s. First thing presented, he has like almost a stroke. By the time we evaluate him, back to normal, got the CTP, there was some penumbra, and we're trying to get all things worked up. The patient, again, was standing up, set up, and had the stroke, so we had to rush him out. So here, given this, how much would you would think that post this will be some pressure? Anyone? What would you think the pressure would be? But I mean, you think it's 0. Yeah, no, because here you can see here there's 0.4 because there's a good collateral. And that's why I go, and if you go back to the ANOVA, if you don't have a good collateral, this pressure would be what? 0. Wait a minute. I'm sorry. Yeah, this pressure would be 0. Okay. So this is where collaterals play a role and change in the equation, if you will. And then this is after we did the mechanical thrombectomy. You could see here the pressure is 0.6, and then we brought him back a few days later, and we put the stent, as you see, and went up the pressure gradient to 0.85. So we published this. We did 9 patients, if you will. We've done more since then, but the way we found out that here there is no correlation whatsoever between the pressure gradient and the stenosis. And now here, I will answer you, I promise you, sir, I will answer you. Here we built a whole trial of 400 patients, extensive millions of dollars, on stenosis, which it has really cannot predict, functionality. I will answer you real quick, guys, but I have 15 minutes, I'm challenged. So this is what we see here. The measurement of the stenosis is not an accurate if it's, especially if it's in that around 70% or so. So that's our conclusion. Angiographic stenosis does not reflect this physiologic severity, and the hemodynamic assessment is the most important thing. Our colleagues from Beijing, they did the similar thing. They started with 20 patients, but they ended up getting only 13 patients, a little bit higher than us, pre and post stenosis, and they found numbers, which we're going to talk about it right here, and they found out that if the FFR, they found out in theirs, if it's symptomatic, it's 0.66. For ours, it has to be 0.6. So if we know the FFR is below 0.6, then you know that the patient is going to have a problem. So you don't have to wait for the patient to have stroke twice on aspirin Plavix to treat. So we cannot, it's not our practice yet, but this is again, suggestion need to be validated. And we suggest, and they, again, our colleagues from China, they found that the FFR for symptomatic is 0.66. So we're very close. So this is two different groups, simultaneously worked on different things. And then the correction for us, it has to be greater than 0.8. Their correction was 0.88 or 84, I'm sorry. So we are very, very good. So so if you don't make your correction above 0.8, you're gonna fail. So now we not only know what's the lower threshold, we also need to know what's the upper threshold that we need to reach to. And that's based on two groups, ours and theirs. So, and we need longitudinal study to validate that. And the most important thing we need to do, as Ricardo suggested, to validate that with ANOVA, because if we can validate that with ANOVA, then and find a way, equation or something, then we move it from invasive procedure to non-invasive procedure, which is easy, accessible. You can do it locally, and the local doctor software can calculate that and refer it to you. So this is where we at. I think we're trying to move from challenge the dogma, if you will, and Sambras hurt us, but it's also helped us to be better and to find better ways to kind of tackle this disease. With that, I left my questions, and I'm less than 15 minutes. Oh, no, you wait. Turn first. Turn.
I'm sorry to speak about a technique I've described a long time ago, which is the cerebral parenchymography, injecting in the ascending aortic arch. You have all the information you need, all. You can do also the Eudaimos test. You know if a stenosis is doing something distally. You know if there is a reaction possible with Diamox. So you have all the information to make the decision to treat.
Dave, I'm glad you mentioned cardiology, because there's a famous saying in cardiology: if you want to stent a vessel, you do IVUS. If you don't want to stent, you measure gradient pressure, because again, degree stenosis is totally, it's arbitrary. It doesn't mean anything for what we do. And I'm glad you're putting work on this. If you talk to Fadi Charbel, that is the guy, neurosurgeon from the United States that developed this quantitative MRA, Fadi offered to do NOVA during Sampras to measure the gradient with NOVA before and after stenosis, and only stent the patients that had a drop, because again, it does not make sense to stent if there's no decrease on. Yeah, so as you said, it has to be validated. I think you're spot on. That lesion that you said that you showed two cases, one you stent, the other one you cross with the pressure wire and you did not treat. Okay, so You said that you would not run a 27 microcatheter in a aneurysm, but you run a wire through a severe stenosis? Under RB, right? Okay, no good. So just to pull your leg from yesterday, payback time.
Do you use the getaway or wire balloon, or you recommend the coronary stent?
Very flexible. We use if you have it depends on the.
And you are only one movement. You don't have you place this and that.
Exactly. Minimize the. Edgar, you like which one you like better?
And
yeah.
Is the pressure in the center is very slow, no? You wait 1 minute, wait.
Exactly. We have a very strict protocol on it. We do understand, yeah.
Like 80%.
Again, when you have that, then you have post-stenosis and things like that.
According to
so what we try, again, what we try to do is at least 50% or more. 50% or more. 50%, but you remember also, we have to get at least successful 50%, because remember, you're constrained with the size of the stents, because some stents is, the smallest we have is 2.25 diameter for the rebel. So, we don't inflate it too much for that stuff.
Thank you. It's a very nice presentation. We also use coronary stents for the intracranial stenosis, but the question, maybe discussion at the point, still have 15% of drug not effectiveness. Correct. And as we said in the morning, we have patients who is not responsible for the clopidogrel resistant. And in usual protocols for the best medical treatment, neurologists and cardiologists give clopidogrel and aspirin, and nobody checked the effectiveness.
That's, again, one of the flaws of the Sambers trial, because in the cardiology literature, there's about 40% failure to response to Plavix. And the same thing, when they did the Sambers trial, they use Plavix, and you're correct. There's some people are resistant to that, and that could be the 15%. We don't know.
Yes, and in our country, as I said, we had to use the local clopidogrel, and we have seen the 50% of resistance.
But in an FDA, if someone comes in with severe stenosis and you put them on aspirin and Prolenta, the FDA says Prolenta increases risks of hemorrhage more than the other one. So how are you going to justify that? If you did that and the patient hemorrhage, just get your checkbook. Kazakhstan doesn't have malpractice. United States, we have malpractice.
It's a problem of this treatment option for this kind of severely ill patients, and it's okay. And from the technical point, do you all the time succeed to pass the cavernous portion of the ICA? And
yeah, we have a technique. So if it's straightforward, you can use a longer stent. You can use 12 millimeter length. If you have an S-shaped, we use a triaxial, and we use also 8 millimeter. So we try to kind of shorten the stent so it can make the curves around.
Distal access catheter made the world of difference for intracranial coronary stent use, because you can put your distal access catheter at the mouth of the lesion.
Correct.
And sometimes we even angioplasty cross the lesion with distal access catheter and do renal stenting or.
This is only Ricardo does that, so don't. So back before I answer.
You just unship the stent. Correct.
For Edgar, so he's trained stroke neurologist. So do you put patient the first time like this patient on aspirin Prolenta?
I mean, we sometimes,
I mean,
even after angioplasty or stenting, you see intimal hyperplasia, and we check the PRU. And these patients that develop intimal hyperplasia, the PRU is not reactive. So some of them we switch them to Berlinta.
No, but up front.
Up front, no. No, usually it's aspirin and Plavix. And then if they're not responding, we switch them.
Our protocol, we test everybody, just like for flow diverter. If this person is resistant to Plavix, we switch up front to Berlin with 3 stroke neurologists on board with that protocol.
That's
and
okay.
we've seen patients failing Plavix, coming with symptoms with Plavix. You switch them to Berlin, they stop having.
But see how like a whole $35 million, $40 million failed for simple things and set the stage completely for people being mistreated in the state.
Do you recommend the usage of bone expandable stents even if the disease segment has a lot of perforators such as striate vessels? Do you still suggesting to use the balloon mounted balloon expandable stents?
As in, my series is small. I had 54 patients, and knock on the wood, I yet to have any problem with perforators. We've done it even in the basilar P1 segment, and so far we haven't had any issues. Edgar, you had done as many as I did.
Yeah, we had a case in the basilar where the problem is you have the snow plowing effect. So you inflate the balloon to deploy the stent, and sometimes you rupture the plaque. So you don't see it angiographically, but you can include some of the perforators. So in the mid-basilar, we did a study of like 90 patients just basilar. Mid-basilar is very dangerous. So try to stay away from the mid-basilar. If it's proximal or distal, is more feasible. But we were careful with the mid-basilar. In the lenticular striates, we haven't had any issues, but mid-basilar can be a problem.
So we have 2 patients that we published on us in public never woke up with a mid-basilar with stent, with a balloon mounted, shut down circumferentially perforated, the whole brain stem was white and disaster.
Especially if the plaque is on the posterior wall of the artery, it is very dangerous to do any balloon mounted stenting. You may get away with a under ballooning, then you may put a stupid self-expandable atlas, neuroform, blah blah blah, enterprise, and then it might be okay. But if you do a real opening, you may dislodge the plaque and then occlude the orifice of the so-called perforators, which have a long trajectory within the wall of the basilar artery.
So what I'm at here is this is mind-provoking, guys. I am not trying to have one way to say this is how you do it. All we need is, as a community, we should be engaged more back and try to be better in addressing this disease and accepting the reality that is being imposed on us by the Sambra style and the visit trial. Those 2 trial fails. Yeah, and so I gotta go so we can so other people can have fair.
One more question.
Yes.
What's the difference between, I mean, you have developed this technique, measuring pressure. What's the difference with just CT perfusion? Why not doing CT perfusion with and without Diamox? What?
Yeah, I mean, you can do that. You can challenge with Diamox. I'm not saying this is the only way that we said ANOVA can be used. You can, if you kind of want to do CT perfusion or PET scan and a challenge, go for it. If it gives you the same data. What we're trying to do, the whole exercise from this is one thing, that the stenosis, measuring the stenosis is the wrong way to assess patient. That was the whole thing, okay? If you can get the same information from CT perfusion, again, we're trying to move from the pressure gradient to something more non-invasive. But you have to validate it. And the best way to validate that is by doing the pressure gradient first, because that's an accurate gold standard for measurement across the stenosis. The CT perfusion till today is an estimation.
No, it's not. It's a real number.
Well, if you ask Greg Alperton of Proof, they haven't validated yet. Yeah. Yeah.